this is Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 4 conversations from Season 3, Episode 18, our preview of the inaugural Innovations in NAFLD Care Conference, which takes place in Barcelona on May 6th and May 7th. This conversation starts with Jeff Lazarus discussing his history with what he, giving credit to this podcast, describes as a tsunami of liver diseases. The idea that his work in HIV led to hepatitis C due to commonality in patients, and the work in hepatitis C led to NASH because as Hep C receded, cirrhosis and HCC continued to grow. This leads to a discussion of what HIV, Hep C, and NASH have in common from a public health perspective and the many ways in which they're different. Jörn Schattenberg carries the conversation forward, discussing how much he has learned about building common public perception since he began working with Jeff in 2018. And the rest of the conversation focuses on key elements in building public consensus and the importance of patient advocacy and public awareness in setting the stage for a major public health effort like this one. The conversation ends with my observation that the 3 diseases Jeff describes are burdened with common public misperceptions about the source of disease that lead to stigma on the part of physicians and public and may create challenges of their own. Congratulations to Jörn and Jeff for creating this unique event. A public health view of NAFLD integrates the things most listeners in this podcast consider every day, like diagnostics, medication, and patient management, with an array of consensus building and public sector education needs like guidelines and endorsements we don't think about all that much. It's a different look. So sit back, listen, enjoy, learn, and when you're done, join the dialogue on our LinkedIn and Facebook discussion groups. Jeff, since this general vision, I think, initiates with you, you've talked a little bit in past episodes about some of the history and how you got to NASH, but if you could do that again for a minute or 3, putting focus on what it is you learned on the way through that made you feel this conference was such a good idea, or a necessity, or somewhere in the middle, your floor.
Jeffrey Lazarus.
I think I'll draw on the title of your podcast, Roger, because I feel like I'm surfing sometimes on the tsunami of one health problem after another. And I mentioned probably last time or the time before that I started my work in global public health and HIV, living in New York City at the end of the 1980s. Everyone knew about the AIDS epidemic. The question was, what were we going to do about it? When I later moved to WHO at the end of the 90s, I worked on HIV. As we started to get that under control, I moved into hepatitis C because we realized we were providing antiretroviral therapy to many people who are going to have liver problems because hepatitis C, like HIV, is a common blood-borne virus among certain populations, like people who inject drugs that we were working with. And as I worked, in hepatitis C and started to engage more and more with the liver community and not just the infectious disease community, so meeting people like Jörn and Manuel, who I just mentioned, and so many other great liver experts, I would say it was more brought to my attention, the issue of fatty liver disease, because, I didn't study this 20 years ago in school or 10 years ago in, continuing education courses. It was there, I knew about it, but I didn't really realize how serious it was. And the more I learned about it, the more I realized we needed to take a public health and a health systems approach to it. That on the one hand, we didn't even have a good treatment. So whereas with HIV and hepatitis, it was about developing those treatments. And then when we had them, getting them to the people, taking an implementation science and delivery science approach. Here, without those, we have some treatments, but not a specific, fatty liver disease treatment. I realized we had to take that public health approach. And that's really how I got into the field. And as I attended conferences, I've been going to the ILC regularly for 10 years, but off and on for 5 years, even before that, and the liver meeting in the US and other liver meetings, I realized that no one was really talking about fatty liver disease from that public health perspective. How do we take a whole of society approach? How do we take a people-centered approach? How do we think about things like, the kinds of models of care that really work for patients and even people before they become our patients who just need to know if this is something they should be worried about or not. So that's how I approached this. And I realized that there was an incredible appetite in the liver community, including among the clinicians, for this approach, but little knowledge about it because it wasn't something that was really taught in medical school, and it's not something that we really reward clinicians for. There weren't a lot of publications on the matter. It's hard to be remunerated. It's just not an approach we've really taken up. So helping to build stronger collaborations with other areas, obesity, diabetes, maybe even cardiology, and just thinking about how we can address this from a different angle is really the approach I'm taking.
Jeff, it strikes me listening to you that sounds less like a tsunami and more like being at sea in a ship during a storm that never ends. On the horizon, the sun is always clear, and every time you get to the horizon, there's another disease.
I guess the tsunami for me, though, is just recognizing that this is a massive, overwhelming wave of not just, I would say, problem, but problems, because this is a metabolic health issue hitting us. And yeah, we're on a ship at sea, but at the same time, I feel like the tsunami's past us and still going on at times.
I didn't get to the point where I talked about the 30-foot seas and the 50-knot winds, did I? Yeah, that's kind of what I envisioned, 10-meter seas and 50-knot winds. Go ahead, Jörn.
Jörn Schattenberg.
But Roger, let me chime in. And because, if I think back, the first paper I did with Jeff, or maybe the first one where I was real conscious about it, was we did a study on disease burden and the economic impact on NASH in 5 European countries. So that was 2018. And for me, everything was said, this is the disease burden, this is how much it costs, so now we need drugs and diagnostics. And Jeff kind of went back and said, no. There's a lot of things you got to settle before you can actually implement care. And I think in succession, and again, Jeff was a key driver here, there was 5 or 6 publications where we said, these are the models we want. This is the consensus. You got to talk to the people. You got to bring them all together and define what you want to achieve. Who are the stakeholders? And like he said, these are all the things, as a physician, I said, this is my patient, I want the drug. But until I get there, there's so much things that we got to actually untangle. And I think the whole process, and again, looping back to how Jeff and I got together, I think it started with cost, but since then, it's been some incredibly productive years in just pulling people together and getting this into a movement that I think finally leads up to the conference we're having now next month.
So, Jörn, on the way there, what was the biggest surprise to you?
Yeah, I think overall, under the leadership, again, of Jeff here, looking from the public health perspective, that we could actually come up with consensus involving, I think it's the consensus paper that we discussed on this podcast before, involving over 200 stakeholders in the field, and just to have, I think it was 3 Delphi rounds, and actually funnel down on the next important steps and get to an agreement. And I think, you have a lot of healthcare experts and physicians, an agreement of what is required now. And then from there, we can actually act. This is the time where we move it beyond the physician's office, where we move it to the regulators, to the healthcare authorities, to the people around us, to say, hey, this is a tsunami. You got to start acting, not just because the physician thinks so, but because we have a broad consensus here. This is the roadmap. This is how much it costs. So this approach is just much more structured than the single physician would take it from an individual patient.
Interesting. So, Jeff, before we go into the agenda, we'll get there in about 1 or 2 questions. How does NAFLD look the most like the other diseases you've been looking at? You mentioned one way in which it's different is that there are no clear therapeutic solutions here. What are some of the ways in which they look alike? And what are some other ways, other than the lack of clear drug choices, that they look really different to you?
Well, I would say NAFLD, reminds me of what it was like when I lived in the U.S. in the 80s and the president wouldn't even mention the word AIDS. There, at least, it was brought to his attention, but there was no public awareness, no real understanding. So NAFLD is just this unknown condition that has so many clinicians, I would say particularly liver specialists, and I don't want to say in a bit of a panic, but of great concern. And the rest of society doesn't know this is happening. So it's literally like a silence tsunami. I mean, it's that moment, when the water's going to hit and people don't even know that it looks calm out there, because we know that the prevalence, is estimated to be as high as 1 in every 4 adults. So it reminds me of hepatitis C and HIV before they became well known. We have an incredible body of knowledge. The good thing, if there can be a good thing about high prevalence, is that, again, with AIDS, as it started to affect well-known people, as it reached high-income countries, that's when the attention turned to it. That's when pharmaceutical companies, really put the pedal to the metal. The drug development was accelerated and awareness was raised. And we have that situation starting to happen as we start to reach, unfortunately, well-known people and more people in high-income countries that are affected and even dying, as we're starting to pinpoint and narrow down, let's say, liver cancer attributable to fatty liver disease and end-stage liver disease and cirrhosis. We still don't always have good studies of attribution. As we realize the role fatty liver disease is playing, it helps us raise awareness among the decision makers, the policymakers, but also our clinical colleagues and even patient groups in other areas like obesity and diabetes.
So are you nodding or are you just thinking?
I was nodding and I was thinking something I haven't said before is, the connection with the patient groups and the advocacy groups. Jeff mentioned that it affects more and more people. I think the phenotype is different. This is also a disease that can give you some discrimination, if you'd like, or putting you in the middle of maybe not having achieved the weight goals that the physician has told you over and over again. Well, why don't you achieve that? So the individual patient is disadvantaged, or he feels bad about his disease. This is not comparable to HIV or infectious diseases, but it's a certain constellation where the patient himself is maybe guiltful about his disease. And that's, I think, where you got to start talking to the patient advocacy groups. And again, this is something also for the meeting next week, but I think in perspective that the public health experts brought in more broadly, and to move this beyond talking to an individual patient with individual guilt and his health problems and potentially social background that caused the disease. And here, the broader community of patients is available to be addressed. And actually, let's ask the patients, what do they want? What type of advice? What will help? What about people that were successful in implementing it? And it's so important to engage with them at that level of global or more broad patient advocacy.
It's interesting. As I'm listening, one of the things that strikes me, and you're right, Jörn, it's not the same level, but there are some really socially biasing misperceptions about the core diseases here, right? HIV was a disease just for gay people and then gay people and drug addicts. Not true, but that was the perception. The Hep C was entirely about people using needles for drugs. That might be where it started, but that certainly isn't where it ended. And you get the blood transfusions and partners and all this other stuff. Here, what we hear frequently from people who come on the podcast is they tell their patients they have cirrhosis, and the patient says, but I don't drink alcohol. And you're right, Jörn. One of the things I used to see over and over again in marketing research, really everywhere in the world we worked, and they were the developed countries, but all of them, was that doctors had somewhere between frustration and contempt for obese patients that couldn't lose weight. That it was obviously a problem of willpower. We're now starting to understand that obesity is a disease. But in the same sense, there's a real miss on communication there. And I hear it as the same kind of thing, if not at the same degree. Does that feel right to you guys?
That feels absolutely right. I feel like we're in a better place than before, that not everyone associates liver disease with alcohol. Maybe I'm just because I'm in an environment where everybody doesn't do that all the time. But yeah, there's just that association. And the other issue, Roger, is the association of non-alcoholic fatty liver disease with being, overweight or obese. And we know that there's a decent-sized percentage of those with non-alcoholic fatty liver disease, NAFLD, that aren't obese either. So, you get this disease, you're not overweight, you're not drinking excessive alcohol, and that's what everybody thinks you're doing. So, we have this huge problem with stigma and discrimination and the name. And if we have time, I'll mention we are embarking now on a large consensus statement, a nomenclature consensus statement to rethink the name and the implications of the current name and a possible name change.
Which is a subject I will note if we get there of hearty debate. And I could put another set of people on next week and go in a completely different direction on that. We'll see.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. We'll be back next week to discuss what the leaders of the NAIL NIT initiative believe we might learn from their retrospective analyses. We may also have some news for you at that time. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.